Welcome, everyone. We'll be starting in just a moment. Welcome to today's webinar. We'll be starting in just a moment. We'll be starting in just a moment. Welcome to today's webinar. We'll be starting in just a moment. All right, well, it looks like we have a fair amount of people that are already populated. So welcome to our webinar. My name is Heather Zemo. I'm the Education Director at IAHSS. Happy Healthcare Security and Safety Week. And I'm so glad you were able to join us today for our webinar that it takes a team to lead, prevent, and intervene a global perspective. Just a few housekeeping things I want to cover before we get started. This presentation is being recorded. So if you're interested in doing the recording after, it will be in the IAHS store, probably sometime next week. There is a chat feature on the bottom. If you'd like to use that to introduce yourself, feel free. There is a Q&A option too on this webinar. So if you have a question for one of the presenters, feel free to use the Q&A at the bottom of the screen. And if we have time at the end, we will go ahead and answer those. Do not put your questions in the chat. They seem to get a little lost. Please use the Q&A option. With that said, I think that's all my housekeeping notes. Today's moderator is going to be Dan Yaros. So I'm going to go ahead and turn it over to him now. Hi, Dan.
Hey, Heather, thank you so much. And hi, everyone. Thank you for joining. We're really looking forward to this panel discussion. And I would just like to say first that this was the brainchild of our president of IHSS, Eric Sean Clay. And unfortunately, he's a little bit under the weather today. So he asked me to step in, and I'm happy to do so. So Eric thought it would be really interesting just to get the perception, hear about how healthcare security and safety works with the clinical side, not just here in the United States, but globally. So we are very, very fortunate to have three expert panelists who I know that we're really looking forward to working with closely as I become president next year, just to continue with the great benefit and value that IHSS provides to everyone that are members, and to help provide a better and more enhanced healthcare security and safety environment. So with that said, our first panelist will be Danielle Austin from Australia. She is the Incident Response and Disaster Manager at St. Vincent's Hospital, and she's also the chapter chair of the IHSS Australian chapters. So thank you for becoming one of our presenters, Danielle. Our second one is Mohammed Hafi bin Rohani from Singapore. He's with Singapore Health Services Operations Shared Services Security Assistant Manager. A lot of work there, so be very interested to hear his perspective. And then we have Daniel Jimenez from Colombia, the organization GDC. He's the director. And then accompanying him will be our translator, Jeffrey Perez. So with that, I want to hand it over to Danielle to provide a little bit more intro for herself and a presentation. So take it away.
Thanks so much, Dan. Good morning, good evening, good afternoon, wherever you are. As Dan said, my name's Danielle. I have the great privilege of being the chapter chair down here in Australia. And I'm actually a clinician. So I'm going to bring a very different perspective, but, you know, part of my role is in responding to escalating behaviors. We call them code black incidents here. I'm the clinical team lead, and I work really, really closely. In fact, our security team is embedded as part of the healthcare team. Just to give you a bit of an understanding, because, you know, there's quite a little bit, quite a bit of difference between what we do here in Australia as to what is generally seen across the US. We're far more similar in terms of our healthcare system to our friends in Canada there. So we work within a publicly funded healthcare system here. I actually work at St. Vincent's, which is part of St. Vincent's Health Australia, that sort of spans the entire East Coast of our country. And we're quite a small tertiary trauma centre right in the middle of Sydney. And so we have quite a complex and diverse patient cohort that we see through our organisation, even though we're a quite small facility in terms of inpatient bed sizes and those sorts of things. We actually see the highest percentage of patients who present with mental health concerns, the highest percentage of patients presenting with comorbid complex substance use disorders, and also the highest percentage of patients coming through our organisation who are experiencing or at risk of homelessness. So we have, we have our catchment area sort of covers the gorgeous, beautiful eastern suburbs of Sydney, which look out over the ocean, where property prices are, ever increasing, all the way through, the full breadth of our community, where we have, we've got an entire homeless health service that just does outreach and looks after those people who are experiencing, homelessness and the stresses of that as well. In terms of our security response, I have the great privilege of working really, really closely with Ross Judd, who's our security manager, and who is one of my mentors in this space. He has been very, very open over the last 12, 15 years. We've been working together, looking at how do we actually respond together? How do we embed our security team into the healthcare team? And he's really taken our organization on a significant journey, really refocusing and looking at how does security operate within the healthcare environment. And, one of the shared passions and beliefs that we both have is that security is healthcare security in particular is a healthcare profession, and really looking at improving the professionalization of our security officers, not just within our organisation, but across Australia and New Zealand, which is why, establishing an IHSS chapter down here was so important to both of us. Apart from the challenges that we all share, I think it's really important to highlight that there's some challenges that we don't share with our colleagues in the US. And, fortunately for us, firearms and the management of firearms is very rare instance. In fact, it's very limited access to firearms here in Australia, and it's generally just police and military that have access to that. It's so that for me, that makes my job a lot easier, but we still have to manage all of the other ins and outs of things that are happening here. And so, I really would love to see questions. I want to hear what, the viewers out there would like to know. I mean, I could talk about this all day. I think it's a really important, discussion that we're having this morning around how do we actually bring together our teams, because I recognize that I sit in quite a privileged position in my organization where we've managed to sort of break down those walls between our clinical and security teams. And I'm not saying it's perfect, nowhere is ever perfect, but we've done a lot of work and we continue to do a lot of work in how do we actually make sure that every member of our healthcare team, and that includes our security officers, is leading together to make sure that we're providing exceptional patient care, but also ensuring the safety and security of all of our staff and anyone that comes onto our campuses. I'm going to leave it there because I know we've got some questions for our panel discussion later. So Dan, are you happy if I hand over to Mohammed?
That'd be great.
Lovely. Thank you.
Thank you very much.
Right. Thanks, Danielle, for the great introduction. Again, I'm truly privileged to be here speaking to all of you today. So basically, I'm from Singapore, and I'm currently serving in Singapore Health Services, or SingHealth for short, as the assistant manager under SingHealth HQ. So just a bit, I'll do a quick one. So basically about myself, I've been in healthcare security for over 10 years. I've served for the past 10 years, I've served in 5 different healthcare institutions, Singapore General Hospital, Alexandra Hospital, a lot of hospitals, and also a specialist center. And my main specialization is basically setting up new healthcare facilities. I have the privilege of setting up two hospitals and 1 specialist center. And I enjoy doing pre-op security planning before the hospital or the healthcare facility sets up, doing licensing, doing drills, that kind of thing. And also specialize in security consultancy and training. And I have my interests are particularly in adult pedagogy, healthcare security management, and workplace violence management. So just to give a context on where is Singapore exactly, not far from Daniel, definitely, just a bit up north. Small tiny country, and with a population of almost 6 million, packed in a small space, almost the size of New York City, if you want to make the comparison. So, and we are a multicultural city. Chinese making up 70% of the population, with significant minorities of Malays and Indian ethnicity. And English is our official working language, despite the many cultural hotspot, which is Singapore. So to give a bit of background on the healthcare system in Singapore, so again, similar to Down Under, healthcare is universally provided, and while it's not fully free, it is heavily subsidized by the government through co-payment schemes, insurance schemes. And Singapore healthcare is largely public, with pockets of private healthcare providers, but majority of its citizens enjoy subsidized public healthcare provided by 3 major public healthcare clusters, as you can see here. Mainly Singapore Health Services, SingHealth, where I'm from, National Healthcare Group, and the National University Health System. And within each of these healthcare clusters, there are several major hospitals and specialist centers located within the west, central, and eastern part of the country. So by far, for where I come from, SingHealth is the largest public healthcare cluster in Singapore, with 4 major hospitals, which includes Singapore General Hospital, which is our flagship hospital in the country, 2 community hospitals, 5 specialist centers, and several primary care providers spread around the eastern part of Singapore. We have the largest staff strength amongst the 3 public healthcare clusters and a major health service provider responsible for almost half of the country's healthcare needs. So we move on our focus to the heart of SingHealth, which is the Singapore General Hospital Campus, or SGH Campus for short. So the SGH Campus houses our flagship hospital, SGH, Outram Community Hospital, where I am located at, and several other specialist centers such as the National Eye Center, Dental Center, Heart Center, and the new Cancer Center, alongside academic medical research centers. If you would ever come to SGH Campus, it is itself a bustling healthcare city, and 24/7 it is always crowded, packed, and busy with patients, staff. And in fact, furthermore, the campus itself is undergoing a major transformation, with new healthcare facilities under construction being set up as part of the SGH Campus Master Plan. So this is where I am located at and currently managing the security operations right here in Outram Community Hospital. It's a large facility with over 19 stories of medical and office use, with 4 basement car park facilities. So OCH is basically a step-down care hospital meant for long-term rehabilitative and palliative care, with around 550 licensed beds and 2 floors of outpatients and ambulatory facilities. OCH caters for a wide range of patient profiles, which includes mainly the elderly and patients with long-term care needs. So here we are, these are our men and women who keep our facility safe. So basically our security team in OCH are mainly outsourced and managed by our in-house security team. We typically respond to many security requests, which ranges from infectious disease, patient escorts, uncooperative or violent patients, workplace violence, intrusion alarm responses, wayfinding. We also play an important role in life and death situations in clinical care, such as for code blue activations, where we are one of the primary responders when it comes to code blue, whether in the inpatient or outpatient settings. And of course, I think the usual work that most of us here are familiar with regards to healthcare security, such as your normal patrolling, traffic marshalling, access control. So as mentioned by Daniel, similarly as for Singapore, our security officers here are mainly unarmed, but they are required to be licensed under our Singapore Private Security Act. And while basic licensing training applies to all security officers, healthcare security officers will receive specialized training catered to each healthcare facility's requirements upon their onboarding to the facility. So training such as de-escalation, how to disengage from violent patients, PPE donning, degowning for infectious patients, code blue protocols. All these are very specialized to healthcare, and our healthcare security officers would undergo these specialized trainings when they are on board with us. Additionally, what is special about our team is that my team is comprises of our one campus security response team, which is a mobile security response force, which roves around our large SDH campus, mainly tasked for campus traffic control and enforcement. So our campus is very busy, as you know, and road congestion are very typical. So the main role of our mobile squad is critical in ensuring that traffic is smooth, so that emergency services, emergency ambulances could relay urgent care patients to our SDH accident and emergency department, which caters for which has a level 1 trauma center. The mobile team also supports other institutions in campus, especially the smaller centers, given their small security staff strength, in regards to incidents that may be out of their scope or that requires backup. Our response team is also for main security incidents, is the main security incident force for campus-wide serious incidences such as terror attacks, major traffic incidents, acting as the initial coordinating incident manager prior to the arrival of the authorities. So as being a campus and healthcare city, any incident that occurs in one facility will definitely affect the next facility, the next neighboring facility. Hence, our campus response team is there to provide that coordinated response prior to the police or emergency services arrival. So my building currently was established in 2019, and it was identified as to be the new SDH Campus Security Command Center. While it's not fully tech capable, our command center is the operational nucleus to perform 24/7 surveillance across the whole campus and disseminate critical security information to the other institutions within the campus as well. And it also acts as the main command and control center that coordinates actions for serious security incidents such as maybe a terror attack in the campus. So our main tagline in SingHealth is patients at the heart of all we do, and this applies to not just our caregivers, our nurses, our doctors. It also applies to all healthcare staff, including our healthcare security staff, which plays an important role in patient care and ensuring that our patients are provided with excellent care. Hence, with that, I will close my introduction. Thank you for listening, and then I shall then pass over to Daniel. Thank you.
Thank you, Mohammed. So we'll move it over to Daniel Jimenez.
Hi, everyone. Give me a second, please. Okay.
You want to sharing, and we'll give Daniel control to open the share. Thank you. Go ahead, Daniel, try to share.
Okay, thank you. Okay, well, I'm Daniel Jiménez. Yo tengo una experiencia de 32 años trabajando en temas de seguridad. Pero lo parte... Oh, dale.
My name is Daniel Jimenez. My name is Jeffrey. I'm translating today for Daniel Jimenez. Everything I say from this point forward will be his words. I have 32 years of experience working in security, including healthcare security in Latin America.
Y he trabajado desde diferentes orillas. Primero como responsable de seguridad de una instalación hospitalaria.
I worked in different fields, including being responsible for a healthcare facility as it relates to safety and security.
Y hoy en día como consultor de diferentes hospitales y clínicas en la región.
And today I serve as a consultant for multiple different healthcare facilities throughout the region within not just Colombia, but throughout Latin America.
He tenido la oportunidad también de pertenecer a esta asociación, a la IAHSS.
I've also had the opportunity of being an IHSS member.
Y he logrado encontrar entonces a lo largo de estos dos, o de la mixtura, de la combinación de estas posiciones laborales y desarrollo académico.
And I've had the opportunity to work on multiple different projects from an academic and a hospital setting perspective.
Además del intercambio con otros profesionales, no solamente de IAHSS, sino de otras asociaciones.
And I've collaborated with other professionals, not only in IHSS, but also in other security organizations throughout Latin America.
Algunas similitudes y diferencias entre lo que son los sistemas de salud y el funcionamiento de los hospitales y clínicas en diferentes partes.
Here are some of the similarities between the healthcare systems and the healthcare products within Colombia and other countries within Latin America.
Dentro de las similitudes, lo primero es hablar de ese enfoque en el bienestar del personal.
One of the first similarities is focusing on the well-being of personnel.
Tanto en safety como en security, lo que buscan es crear un entorno completamente seguro, tanto para pacientes y empleados.
The intent, both in safety and security, is to create a healthy, safe, a safe health care providing environment within all institutions.
Otra de las similitudes que he encontrado en los diferentes hospitales es el cumplimiento normativo.
Another similarity I found between different healthcare organizations in Latin America is the need to comply with regulatory requirements.
Países como Chile, Ecuador, Perú, Venezuela, México, República Dominicana y otras donde tengo la fortuna de ser consultor, tienen unos sistemas normativos bastante exigentes para el segmento hospitalario.
In many countries that I've worked at, such as the ones mentioned, I have found that there are some very strict and difficult to comply with regulations as it relates to healthcare security and safety.
La gran mayoría exigen unos estándares de seguridad y de protección para estas infraestructuras.
The majority of them require a certain degree of standard for healthcare security as it relates to not just patients, but staff as well.
La tercera y gran similitud que tienen todos estos países donde he trabajado
The third similarity that exists between the different Latin America countries wherein I've worked
es la capacitación, el entrenamiento del personal.
is the need to provide training for personnel.
Y es que la formación o el entrenamiento es un ejercicio fundamental, crucial, súper importante, tanto desde el punto de vista de safety como de security, para asegurar que el personal esté verdaderamente preparado para manejar situaciones difíciles, situaciones de crisis.
Training is a foundational, required, and incredibly important initiative for both healthcare security and safety in order to make sure that staff is prepared to deal with difficult and challenging situations.
Por otro lado, también encontramos unas diferencias.
There's also several differences.
La primera de ellas es ese enfoque cultural.
The first one is the cultural focus, the difference between different countries in Latin America.
La percepción de security y de safety puede variar de un país a otro, afectando la implementación de las mismas políticas.
The perception of healthcare security and safety can vary greatly from one country to another, which in turn affects the ability to implement solutions.
Con respecto a los recursos disponibles,
The other difference is as it relates to available resources.
las diferencias en la inversión, en tecnología, entre países, entre ciudades, y teniendo en cuenta ese enfoque cultural también puede impactar la capacidad de implementar algunas medidas de seguridad.
The differences in available resources and investments made, differences in perception of culture, all of which affect the ability to implement solutions that are necessary to tackle some of the challenges associated with healthcare.
En tercer aspecto de las diferencias
The third difference
están las estrategias de gestión. Y es que en algunos países la seguridad puede estar mucho más centralizada o en algunos otros puede ser completamente tercerizada, lo que podría en un momento determinado generar o restar importancia a la gestión propia de security de la organización.
The third difference is in management strategies throughout different countries. In some organizations and in some countries, security will be part of their central strategy. However, in other organizations and countries, security is seen as a separate, independent entity, and that creates challenges.
Ok, uno de los temas que convergen independientemente de las similitudes y diferencias en todos estos países y donde tengo la fortuna de ser su consultor,
And then in some of the principles in order to provide a effective healthcare security in some of the countries that I've worked at are the following.
es que todos aplican estos principios: el conocimiento, el entrenamiento, la humanización del servicio, la pasión por el servicio y el compromiso.
These principles apply to all of the countries that I've worked at all throughout Latin America: knowledge, training, humanity, passion, and engagement.
Pero hay algo más importante sobre todo esto, y es que hay una gran tendencia global a que todos los servicios dentro del mundo del healthcare se realicen y se brinden con empatía y con respeto.
However, there's something else that's also very important. There's a trend all throughout the world that healthcare needs to do more to focus on empathy and respect.
Y bien, pues esto es lo que se vive más o menos a grandes rasgos en Latinoamérica o en algunos países de Latinoamérica, sin decir con eso que sea la regla. Simplemente es lo que yo he logrado percibir y lo que quiero compartir hoy.
And that is it for my introduction as it relates to Latin America, the differences and similarities between the different countries. And that is what I wanted to share today.
Lo último es hablar sobre cómo muchos hospitales y clínicas, particularmente en la región, están empezando a tener o a generar una importancia con respecto a una visión integral que combina safety y security.
The last item I want to talk about is how in Latin America, throughout different countries, there is a trend in having a comprehensive vision that includes and combines both security and safety.
Ahora bien, necesitamos entender que esta industria es transversal en diferentes países.
It's important to understand that this industry varies from country to country.
Y eso debería hacer que logremos generar colaboraciones entre diferentes países con características similares.
And what that does is it raises the need to collaborate between different countries with similar challenges and share best practices and resources.
Y finalmente, es un llamado también para que podamos entender que hay una cantidad de posibilidades para explotar a nivel de la seguridad hospitalaria, que hay demasiadas características que podemos en conjunto como profesionales, como asociación, generar para llegar más lejos.
Also, it's important to focus on the many varied opportunities that exist throughout different organizations, throughout different countries, and doing more to collaborate and doing more to find best practices.
Eso es todo. Muchas gracias, Jeff.
That's all. Thank you.
Well, thank you so much. Really appreciate all three of our panelists with their introductions and with the brief presentation of healthcare security, safety, and culture in the respective areas of our world. So why don't we start with a few questions that we have, and just want a reminder to all of our attendees that if you do have a question, please put it in the Q&A section down below on your screen, and we'll keep an eye out for those. But the first question, and why don't we direct this first to Daniel down in Colombia. How is safety and healthcare protection perceived in Latin America?
Daniel, una pregunta. ¿Cómo se percibe la seguridad y la protección sanitaria en Latinoamérica?
La gran mayoría de países, gracias Jeffrey, la gran mayoría de países lo perciben como dos componentes independientes en la que cada uno tiene sus responsabilidades, pero que convergen y le aportan al negocio como tal.
So it's a good question, and most countries perceive safety and security as two separate entities within their organizations, but both equally important in providing an essential service to their organizations.
Sin embargo, también es importante entender que la seguridad como security se enfoca mucho es en la parte reactiva, en el uso de oficiales de seguridad y de alguna seguridad electrónica.
It's important to highlight that security in Latin America is typically focused on reactive measures, such as using uniformed personnel officers to provide reactive capabilities, and also in using technology for those same reactive capabilities.
Great, thank you. So for our other panelists, how is safety and healthcare protection perceived in your parts of the world? Danielle, you want to go first?
Look, it varies from organization to organization. Certainly here, it was traditionally security was seen as, the lock the doors, last resort, all of those sorts of things. And we've really, tried to change direction and take a complete 180. I really believe that healthcare security is a healthcare profession, and it's an integral part of how we operate our services. And we can't, as clinicians, we can't actually provide safe care if we're not safe. And so we are very reliant on our security team for all of the traditional security roles that they still fulfill, but we've brought them into the healthcare team. So they are part of our multidisciplinary team. And when we're looking at, issues particularly related to patients and behaviors that really challenge us, they're right there with us. So we're actually providing them with clinical education on what some of the clinical drivers are. They're part of our planning around particular patients and how we're going to manage particular patients who pose a risk to either themselves, to staff, to others. And so, I think we've hit a sweet spot in our organization, but that's been a long work in progress and requires, to not only find those people passionate in your organization to go in that direction, but also to be able to take the rest of your organization on that journey with you.
Great, thank you. Mohammed?
Thanks, Dan. So, and for Singapore particularly, I think traditionally security officers in the country are seen as low-skilled workers, and this cuts across every industry, say commercial security, office security, even healthcare security as well. So how we are trying to change that perception by professionalizing the image of our security professionals in the country through various means by our government, such as raising wages and having more advanced training for our security officers to enhance their professionalism. In terms of healthcare security, again, the perception of the public towards healthcare security officers are similar to what they see in, say, in the commercial side, in residential security. They are seen as like basically security guards, and their role in, they do not perceive security as part of the patient care team. But what we are trying to do now is that we are trying to incorporate our security teams to be part of the patient care team through involvement in certain patient care things, such as maybe, for example, like for my organization, we are involved in code blue response, performing CPR, life-saving techniques, as well as performing patient watches, and also assisting our clinicians in terms of, especially when there's a occurrence of violent patients. So we are slowly moving towards that direction of having that perception that security officers, healthcare security officers particularly, are also part of the patient care team, and also regarded as healthcare workers, not just security guards. Yep, thanks.
Thanks, Mohammed. So on the next question, let me start with you first. So we all face, workplace violence. It has only been increasing, probably in all of our countries over the last couple of decades, but even more so, it's been emphasized probably since the pandemic, from 2020 and on. So be interested to know, how is workplace violence impacting your department, your organizations, and healthcare in general? So Mohammed, you want to take the lead first and go ahead?
Sure then. So it's a very good question, especially in the context of Singapore and the larger Asian region. Workplace violence, it could be said to be a taboo subject. I think in terms of our cultural context. So basically, workplace violence, as you mentioned, has been happening for decades, and it has been a pertinent problem. It has only been escalated, as you correctly mentioned, during COVID. And during COVID, there was a lot of unhappiness amongst the public towards healthcare workers and stuff. So this workplace violence problem has escalated to a point where it becomes media stories, especially in Singapore, and it has been highlighted in the media. And what the government has done, we have rolled out an initiative for the past work here, is that the government is moving towards a campaign for anti-abuse, and the campaign has been very rigorous and very strong in terms of having media campaigns publicizing about our enhanced laws towards abuse towards our healthcare workers, and also what are the penalties, and messaging towards the patients that healthcare workers needs to be safe in order to perform their clinical duties. And in terms of for healthcare facilities such as ours, we are moving. My cluster, Sing Health, we are going towards this standardization of training in terms of the management of violence, de-escalation training, how to disengage from violent patients. So this has been standardized across, because previously it was not standardized. It was mix and matches, and mainly the response was based on experience and not by training. So now that we have a standardized training plan for all, including clinicians and security officers, I think moving forward, the management of violence in healthcare would be much more manageable and better taken care of. Thanks.
Thanks, Mohammed. Danielle?
Look, it's a problem we share. It doesn't matter where we are in the world. Is how do we manage this ever increasing problem? And saw it firsthand. Unfortunately, during the pandemic, it really got amplified, and it didn't matter what environment we were working in, whether it was out in the community or within the organization. We certainly saw, where our staff were being wedged between patient expectations, frustrations, all of those sorts of things. It really became a significant issue, causing a lot of psychological harm as well as physical harm to our staff. So our organization over the last 6 to 12 months has decided to really radically look at how we're addressing this issue, because we can't keep doing the same things over and over again and expecting different outcomes. And I think we can all agree that because, we've been working at this problem for decades now, but it's only getting worse. How do we do it differently? So, we've set up an operational safety task force that really looks from, the front line up, and then from, board to ward back down, about how do we address this issue in all of its facets, and how do we take a collaborative and cooperative approach. Doesn't matter where you work and what your role is in the organization, safety is everybody's concern. So, we're really looking at how are we empowering our clinicians, how are we training our clinicians. We're doing a lot of, engagement with our staff who are on the floor to really get, a really good understanding of what they're seeing, but finding out what those amazing little solutions are out there in the organization. There's been some fantastic things out there. We're literally in a couple of hours launching a brand new nursing clinical leads program in behavior support, which is really going to role model with senior clinicians across the organization. How do we actually approach this problem when we do have patients and families and carers who are escalating and challenging us with their behaviors? And then, really looking at, from a security infrastructure perspective, how are we using our tech and investing in our technology to better support all of the things that we're doing in this space? So, really looking at it from all angles and, out of the box thinking, because, as I said, you can't keep doing the same things and expecting different outcomes.
Very good. Thank you so much, Danielle. And Daniel, so how is workplace violence impacting your organizations in Latin and South America? Or I should say Central and South America, I'm sorry.
Daniel, la pregunta es cómo está impactando cómo está impactando la violencia del campo laboral a las diferentes organizaciones de la salud en tu región.
Wow, es un gran problema, ¿no? Tal cual como se maneja a nivel global por estadísticas, en Colombia no es diferente ni en los países de Sudamérica. Es algo que es una gran preocupación.
It's just not much difference compared to the rest of the world. It is also for us in Latin America, particularly in South America, a cause of big concern, and it's a significant impact to operations.
Hoy en día hay grandes esfuerzos de diferentes organizaciones del sector de la salud por mejorar o por empezar a practicar algunos controles que mitiguen el riesgo de violencia en el lugar de trabajo.
There are currently a lot of different efforts from different healthcare organizations that are targeted towards trying to mitigate the impacts of workplace violence in healthcare.
Pero también juega algo en contra, y es el tema cultural, la conciencia situacional de las personas.
But something that negatively impacts that capability is the cultural perception of healthcare security and safety.
Quizás uno de los principales segmentos donde yo he encontrado mayor resistencia es en los médicos y médicas en este tipo de instalaciones?
Where I've seen that there's most resistance to change and to supporting these initiatives is with the clinical personnel, particularly with providers within traditional healthcare institutions.
He recibido respuestas como que soy médico, estudié para cortar y eso es lo único que voy a hacer.
I've received responses from physicians such as, I am a doctor, I studied for such, and I'm prepared to do surgeries, and that's all I care about.
El tema de seguridad no es conmigo.
I have nothing to do with security.
Y ante ese tipo de postura de los médicos o del personal asistencial que la adopta,
And since the doctors have that particular perception, it therefore trickles down to the supporting staff that provides clinical care.
es necesario establecer estrategias amigables para poder abordar y tocar la conciencia de las personas.
It's important to find strategies that will help find a middle ground with clinical staff and particularly be effective in targeting their conscience.
Eso.
That's all.
Great. Well, thank you so much, Daniel. And since we have you, why don't we start the next question? What could be the main obstacle in improving the safety and protection of healthcare facilities in your region? And we'll go around the table then and let you all the rest of the panelists think about that and then answer, but we'll start with Daniel.
Otra pregunta, Daniel. ¿Cuál puede ser el principal obstáculo en la mejora de la seguridad y la protección en las organizaciones de salud en tu región?
En principio, yo creo que es la cultura situacional, la conciencia de la alta dirección.
The culture and the conscience of those in leadership positions.
Porque en principio siempre van a buscar, por lo menos en esta región, una persona que haya tenido algún tipo de afinidad o con la policía o con las fuerzas militares.
Leaders within healthcare institutions will typically look for someone to lead their healthcare security and safety programs that has a background either in military or in law enforcement.
Y la visión autoritaria de las personas que se ubican en estas posiciones
And the individuals that have those type of backgrounds typically have an authoritative view or approach.
hace que se desenfoque generalmente lo que es un programa de seguridad pensado y diseñado para este tipo de negocio.
And therefore, that approach makes it so that they focus on healthcare security and safety programs that have a very narrow perspective and focus.
Esa es la principal, pero no es la única. También hay temas como la falta de inversión en el momento en el que se ve la seguridad como un gasto única y exclusivamente que a todas luces y desde el punto de vista financiero lo es.
That's not the only obstacle, it's definitely the main one, but another obstacle that impacts the ability to provide healthcare security and safety is the investments that are dedicated towards healthcare security and safety. In particular, the fact that there's a lack of investments that for those types of initiatives.
Y la falta de sustento por parte de los responsables de seguridad de los proyectos que se presenten hace que sea algo difícil de entender.
And then another challenge is the lack of basic needs being fulfilled for those that are in positions to provide care and safety and security.
Very interesting. I know everything that Daniel is speaking about just now. I've seen it firsthand or heard it from other organizations here in the United States, same exact issues. And so Daniel, I'm looking forward to seeing you in a few weeks as we can talk. Yeah, it'll be interesting, but I appreciate your insight. Danielle, how about going next?
Sure. Where do we start? There's a few things. I think, number one, first and foremost, and I know this is shared globally as well is, how do we attract the right people into the industry? How do we attract the right people into becoming security officers, particularly those people with the necessary skills, the communication and engagement skills that are really required, particularly in healthcare. And healthcare security is a completely different, environment to other, sort of commercial, retail, all of those sorts of security industries. And so how do we attract the right people into these roles, particularly when, we're challenged by being able to offer appropriate remuneration for people with that level of skill? And so, how do we set ourselves differently in attracting the right people? And then how do we get our boards and, our executives to understand the importance of putting the investment into future-proofing the technology that we're utilizing in the security space as well? Being in a, publicly funded healthcare system here, it's very difficult to find dollars at times, particularly for things that aren't immediate need. And so, we've constantly facing challenges of trying to find the dollars for, not only just keeping our security infrastructure systems running, but how do we actually, invest more proactively into systems that are going to, address problems that we may not currently have in the future. So it's really about how do we frame the narrative and, not only bring our frontline staff along on the journey, but how do we actually influence our C-suite and that into recognizing that investment in, this space is a really important thing. And so we're finding the balance of how do we, compare dollars for dollars on, the security investment side versus the dollars going out on lost time injury, staff turnover, and all of those sorts of things. So it's about finding where to pitch and what the narrative is and, attracting the right people into your organization.
Thanks, Danielle. Mohammed?
I think to add on to what Danielle mentioned, other than the quality of security officers that is lacking, I think globally there is a lot. It's about the quantity of security officers. In other words, everywhere I think we are facing manpower shortages in the private security market, and additionally to getting the right people to join healthcare security is very much difficult. So I think over here we face an issue of attracting talents, and giving the shrinking numbers of manpower supply, as mentioned previously, I think also to counter these manpower shortages, investments in security technology would be required to augment security operations. And I think I would say that across the globe, I think healthcare leaders have find it difficult to invest in something that's not immediate, such as security technology, and the lack of investments and the lack of courage to invest in security technology by healthcare leaders could be seen as an obstacle to enhance our security operations, despite the increasing manpower shortages and the lack of quality people joining healthcare security. And I think also in general, there's an increasing expectation towards healthcare security services. Clinicians are demanding a lot more from our healthcare security officers, demanding more services to be provided, such as I think patient watch, patient escorts, and again, due to manpower shortages, there might be some difficulty in matching these expectations between for our clinical staff. And I think lastly is also the lack of understanding in the limited powers of security. So personally, I find that our clinicians have that perception that security can do 5,000 things. They can catch the guys, they can catch the bad guys, they can detain them, that kind of thing. But again, they lack that understanding that these officers are private security officers. They are not vested with police powers, and the have limited powers in terms of detaining or even like getting the patients out of the facility. And at this stage, we mainly rely on our police force to come in. So I think that's that lack of understanding we will need to counter with more education in terms of the legality of the powers of the security officers over here. Thanks.
Thank you, Mohammed. So a question to all of our panelists, going back to the theme of workplace violence. So how do your respective organizations manage patient-generated violence? Danielle, you want to lead off?
We now view this as a clinical issue. This is very much in the hands of the clinicians now. Our security team are there to provide us with support, and they're part of that healthcare team. But we've recognized that unless we take this from a clinical perspective and respond to it in the very same way and view it as a deteriorating patient, then we can discharge patients, we can remove patients, we can do all of those restrictive practices that we used to do quite frequently, but it doesn't actually diminish the problem and it doesn't improve the safety for any of our staff or for our patients. And really just putting it back onto our clinical teams to say, hey, these are our patients. If we're going to talk about patient-centered care, then that also has to include the challenges that come along with that. And so, really making sure that we are getting in there early, identifying patients at risk, having those multidisciplinary discussions. And, I recognize some of the challenges that our medical colleagues can pose to all of us across the system, but, really making sure that they understand, hey, this is not just we allow somebody to deteriorate until these behaviors become unmanageable, and then you expect our security staff to put themselves at risk to manage these things. We need to get in there early. We need to get in there proactively, put, safety and security measures in place. And these are the discussions, and our security team are at the table for every one of these discussions. And we're further formalizing that. And they are engaging with our clinical team leaders on every shift and making sure that they're having those discussions about where those risks are sitting across our organization and being involved in, the behavior support planning around those patients.
That's great. It almost sounds like the last organization I worked in, so it's well done. Appreciate it. So, Mohammed, patient-generated violence, how do you all handle that there in Singapore?
Yep. I similarly, again, patient-generated violence is mainly a clinical issue, as the member has mentioned, and security's role is mainly a supporting role. We are typically the secondary responder. Usually, the first responders are, of course, the nurses on the ground. And once and when things get out of hand, they will activate security, and our security would deploy a response team to go up and probably talk to the patient, try to de-escalate the situation. So sometimes what we see is that sometimes patients these patients probably in the context of my facility is that because it's a community hospital, and we mainly have and our patient profile is mainly the elderly. And again, as I mentioned earlier, the composition of Singapore is very multicultural, and majority of our population is Chinese, and Chinese is just not, and the Chinese stock has different dialects. We have Hakka, we have Hokkien, we have a lot of Chinese dialects, and especially the elderly, they do not speak Mandarin, which is the vernacular language, Chinese language in Singapore. They will speak in different dialects, Hakka, in Hokkien, in Teochew, and especially the younger ones. And we have a lot of foreign nurses from the Philippines, from Myanmar, and they could not communicate with the elderly who speaks dialect, and even our local staff who are not so proficient in dialect, there's that language barrier. So hence, because of that language barrier, patients become more frustrated. And how we try to help in this situation is that it is also important that our security team is made up of different races, different ethnicities, and with a different language competencies. And for example, my team has we have an elderly staff who's around, I think 50 plus years old, and he can speak a rare dialect in a rare Chinese dialect, and he managed to talk down a patient who was struggling, and even the doctors and the nurses couldn't go through to him. And when he spoke in that local dialect, the patient finally calmed down. So I think in terms of, I think in the context of Asia, or maybe in Singapore, where it's very multicultural and a lot of aging population, I think how we deal with this is that in terms of language barrier, we try to de-escalate the situation by having somebody of the same ethnicity and the same language proficiency, so that there'll be more understanding, and we could de-escalate the situation further before it gets out of hand. Yep, thanks.
Thanks, Mohammed. Daniel, so down in Colombia, so how do you manage patient-generated violence?
Daniel, la pregunta es, en Colombia y bueno, en Latinoamérica, ¿cómo es que manejan la violencia causada por los pacientes?
Como lo mencioné, es completamente reactivo. Hay planes y programas, pero en esencia es completamente reactivo. Es decir, te golpean y vas a saber quién fue el que te golpeó para intervenir.
Unfortunately, it's all very reactive. There are plans and programs in place, but the application of it is only in reactive focus. So if a healthcare provider is punched by another individual, at that point, then they try to figure out what they need to do.
Y lo que pasa es que tanto hospitales como clínicas, en algunos casos, rehuyen la responsabilidad de la afectación a las personas.
And another difficulty is that in both traditional healthcare organizations and hospitals and in clinics, the leadership teams tend to avoid the responsibility that falls upon them in providing safe environment.
Y trasladan una responsabilidad propia de ese hospital o de esa clínica al proveedor de servicios de vigilancia, a la empresa de seguridad.
Rather than taking ownership of that responsibility of providing that safe care environment, they tend to pass the responsibility, subrogate the loss and the liability over to contracted security services.
Así se gestiona aquí en la región.
That is our challenge.
It does sound like one. I appreciate that. So, so since we have Daniel still, I'd like to one question, I guess, specifically to you is, how could the participation of security professionals from hospitals and clinics in Central and South America be increased in the implementation of just improving the overall safety and security of your facilities?
Otra pregunta, Daniel. ¿Cómo se podría incrementarse la participación de los profesionales de seguridad de hospitales y clínicas de Centro y Suramérica en la implementación de las mejoras?
Yo creo que lo más importante, Jeffrey, Dan, es que se tenga acceso al cuerpo del conocimiento. Uno de los principales problemas que tenemos en la región es que la ciencia no habla español, es decir, está en inglés, y nuestra región es más orientada al español.
One of the challenges is the lack of availability for healthcare practitioners, healthcare security practitioners, to have access to the greater body of knowledge that exists as it relates to healthcare security and safety. And as a result, there's challenges in being able to apply and learn about those best practices. Science is usually an English-derived practice and lacks that Spanish translation that our countries so desperately need.
Es uno de los principales problemas que tenemos, pero también es una de las principales oportunidades que podemos encontrar, y es expandir todo este cuerpo del conocimiento a las personas que, como lo mencioné hace un momento, han hecho tránsito o que tienen unas edades o que son muy jóvenes, mejor, y que están haciendo incursión en esta industria tan vertical?
It's one of our greatest challenges, but also a great opportunity in being able to find a way to translate and make it more accessible, that greater body of knowledge and that information, those best practices, and pass that on to the younger generations that are now entering this career and trying to start a find their role and find their place within these healthcare organizations.
Es lo que necesitamos, no más.
And that's what we need.
No, I appreciate that. And Daniel, we hear you up at IHSS at the headquarters that we just had recently our board meeting to set the 2025 through 2027 IHSS strategic plan. And well, I can tell you one theme that the entire board was 100% behind was investigating economical ways that we can start translating all of our material, at least the guidelines, which hopefully everyone is using out there, but also our training courses, our certifications. We're going to start with Spanish, and that's a huge undertaking. It's very expensive, but we as a board has decided to include that in our strategic plan over the next 3 years to begin investigating how to make that happen and translate for the Hispanic population. So more to come on that. And but we appreciate that, and we fully understand, and we hear you. So let's move on to I'll tell you, if Danielle and Mohammed, you can take the same question. How could the participation of security professionals from hospital and clinics in your regions help improve, enhance the overall safety and security of the healthcare environments?
Maybe I'll start. I think as we are very familiar, healthcare security is very much different from the other subfields of security out there. And healthcare security is very specialized in terms of how operations is run, and how, because due to the fact that we have patients and various different groups of people in that one small facility. And I think what can help to enhance what healthcare security professionals can do to enhance the security experience for the organization is, again, to adopt existing guidelines, as Dan has mentioned, from IAHSS. I think the association has a lot of operational guidelines that we can follow, and in fact, even though it's mainly catered towards the North American audience, much of the guidelines can be used internationally, and it can be used in anywhere in the world, and it applies for every healthcare facility in the world, I would say. And through this, we can also standardize and adopt best practices from the association guidelines, and also probably have this kind of webinars, sharing sessions to share good best practices amongst healthcare security professionals, and how to learn best practices from each other. Thanks.
The whole reason we really started the Australia New Zealand chapter down here was because, you know, the support of the association and the professionalization through the use of guidelines and standardized training, because, you know, it doesn't matter where we are in the world, it is the same in healthcare security and safety. And so, you know, we were like, instead of trying to reinvent the wheel just because we're in a different part of the world, it was like, let's actually take on board what's already there, what we know works, what, you know, it's evidence-based, and really try and bring everybody else along on the journey across Australia and New Zealand in this space, because, you know, I recognize that I'm very privileged to work in an organization with a security manager who is very, very different to some of the other security managers that I've worked with over the years in healthcare. And so, you know, making sure that we're looking at how do we lift the profile of our security officers internally, because they are integral to everything that we do. And you know, I'm so proud of the team that I get to work alongside every day. But then how more broadly across the health systems here, how do we raise the profile of healthcare security? How do we raise the standard of professionalization? Because similarly to Singapore, we just have a standard, you know, class 1C security license that doesn't come with any specialist training that's required to actually work within healthcare. So you can be working in a, you know, a bar or a licensed premise, and then you can come and do a shift in a hospital. And as we all know, they're very, very, very different environments, except maybe the emergency department waiting room on a Friday night. But, but you know, making sure that, you know, as we, you know, move through, sorry, it's the middle of the night here. I just glitched a little bit. Just making sure that, you know, everybody within the healthcare system recognizes the important role that healthcare security professionals play, and how, you know, without them keeping us safe, we can't provide safe care as clinicians, particularly.
Well, thanks, Danielle. I fully understand. If I had to work third shift, I'd probably have the shortest career ever. Fall asleep my first tour. That's much appreciated. Okay, so there's been some interest in, can you all describe what type of equipment, what type of defensive tools, if you will, that the officers carry in your organizations? So Mohammed, you want to lead off?
Sure, then. I think as mentioned, our officers are mainly unarmed. A typical, I would say, your typical uniform and boots. Probably the walkie-talkie can be used as a weapon, but yeah, other than that, they are fairly unarmed. But the thing is, what is special in our organization is that we employ auxiliary police officers, and in Singapore, we do not. I mean, firearms are not allowed, and there's only a few companies that has these auxiliary police officers, and we typically contract a few auxiliary police officers especially in A&E, because of the profile of patients and the number of cases, violent cases in A&E. So typically hospitals will employ one armed police officer in the A&E, just to as a deterrent in case of any violent cases. But there's also the risk of the police officer being disarmed. So there has been several cases, I would say 2 cases for the past 5 to 10 years in Singapore, that patients try to attempt to dislodge the revolver from the holster of these police officers, and that's the risk that we will have to take. But hence the ministry has only allowed only one armed officer to be inside A&E. But across the board, mainly the security officers are unarmed, and yeah, that's for Singapore. Thanks.
Thanks, Mohammed. Daniel, what type of equipment do the security officers in your organizations carry?
Is that me, Dan? Sorry.
Yeah,
Or
why don't you
Daniel?
take it?
Okay.
It was Daniel, but go ahead, Daniel. I got you on.
We're all here, the 3 Dans. Yeah, no, they have their wonderful communication skills. That's the tool that they carry. We have completely unarmed security officers. We work closely with our local police, and we're very lucky to be supported by 5 police area commands, they're called here, who do support us as required, but we try and minimize that as much as possible. And so it would have been in about 2012, 2015, I don't know, it all blurs, pre-COVID, New South Wales Health made a decision to actually remove batons and handcuffs from healthcare security officers, which obviously caused a lot of concern, mainly from clinicians. They thought it was going to be extraordinarily detrimental, even though all of the objective data that we had on it was that they weren't actually being utilized very often, and when they were, it was probably not appropriate. So we've really changed our focus on making sure, similarly to Mohammed, our security team is, multilingual. They've got amazing de-escalation skills, and that's it. That's what we expect from our security officers: how to engage, how to communicate with their colleagues, their peers, our patients, all of those sorts of things. But following a critical incident at another healthcare facility, New South Wales Health is now undertaking a trial on body-worn cameras. So that is coming out in the next 6 months across our system, which is a very, very big step for our healthcare system.
Thanks, Danielle. And Daniel, is your answer any different than the other two panelists? What type of equipment do your officers carry down there, if any?
Daniel, la pregunta es, ¿qué tipo de herramientas defensivas usan los oficiales en tu región, sabiendo de que puede variar de un país a otro? Claro, la respuesta.
Bien. Pues la gran mayoría de veces lo que utilizan es el bastón tonfa. Acá en la región, en la gran mayoría de países, a diferencia de Estados Unidos y quizás otros países fuera de las Américas, no se utilizan esposas. El hecho de no utilizar o de tener ese tipo de restricción, obviamente disminuye el riesgo, pero los pacientes o los generadores de violencia pueden hacer uso de diferentes armas. El oficial de seguridad entonces está obligado a emplear su conocimiento y el personal asistencial, la capacitación también que ha recibido y que pronto recuerden aplicar en ese momento.
So in the majority of cases, and in most countries in Latin America, officers tend to carry batons, but not much else. Particularly, it's rare to see them carrying handcuffs. And what that means is then supplemental training has had to be provided to these officers so that they can handle situations where they are out armed and facing a aggressor who has capabilities of providing harm that they are lacking the ability to defend from.
Se están empezando a trabajar algunos programas de prevención e intervención de violencia en el lugar de trabajo desde el punto de vista del staff médico. Médicos, enfermeras, camilleros, personal de apoyo y seguridad. Todos se vinculan para mejorar la respuesta como equipo, no como individuo.
Several initiatives have started in multiple organizations where the clinical and support staff will jump in and help security personnel in de-escalating and even physically intervening in hostile and aggressive situations.
Eso es lo que estamos haciendo.
That's all.
Oh, thank you, Daniel. So we have about 11 minutes or so. So I'd like to ask one more question, and then if we have time, I have a really good one. I'd love to hear from all of you. So the next one is trauma-informed care. Do your organizations use that, and are the officers trained in trauma-informed care? Mohammed, do you have to lead off again?
Sure then. Actually, trauma-informed care is quite a fairly new concept to me and also to the organization itself. I think for now, we are fairly reactive, and reaction to patient-generated violence is basically de-escalate, de-escalate, and de-escalate. And I think particularly for trauma-informed care, I think it's quite an important aspect in terms of knowing your patient before having to even de-escalate the issue, so that the officer has context on what the patient is suffering, and how they can use that context to de-escalate the situation further. And I think recently I went through that the standardized training for de-escalation and physical intervention for violent patients. And what we went through is that we are training our clinicians and healthcare staff to recognize psychological the psychological background of these patients before engaging them, so that we can effectively communicate to them and de-escalate the situation further. But again, for us in Singapore, this trauma-informed care is quite a new concept for us to grasp. Thanks.
Well, thank you. Danielle?
Look, this is a big focus of ours. Really getting all of our staff, our clinical staff, recognizing the role that, trauma plays in how people respond, the responsive behaviors that we're really talking about here when we're talking about patient-generated violence. And so we're spending a lot of time with not only our clinical staff talking about that, but making sure that when we do have, patients that are very high risk of those aggressive behaviors, that our security staff are aware of what's actually happening in the background, because we know that, in Australia, 65% of Australian adults have an experience of trauma in their lived experience. And therefore, sometimes the restrictive practices that we have to engage in to safely manage patients, reinforce that trauma, and then therefore make it more difficult in the future to continue managing in a therapeutic way the needs of those patients. So, it's everybody, I think it's new to most people outside of the mental health space here particularly. And so just spending a lot of time, increasing that general knowledge across the organization.
Very good. Thank you, Danielle. And Daniel?
Daniel, la pregunta es, en tu área, ¿cómo se está aplicando la atención informada de trauma?
Bueno, pues funciona de diferentes maneras dependiendo la ubicación. Sin embargo, tal cual como tiene que hacer, el ejercicio empieza a fluir desde la misma parametrización de la alta dirección, de sus procedimientos, del cumplimiento de las políticas.
The implementation of trauma-informed care varies greatly from country to country, but ultimately it falls down to the individual organization's leaders' implementation of such in the standards and policies that they dictate. So it varies from organization to organization.
Y un proceso de auditoría y seguimiento que verdaderamente hace ver que sí está vivo.
And there's also a lack of a formal audit process to determine whether or not trauma-informed care has been correctly and successfully applied within organizations.
Daniel, so in respect to organizations, if they do use trauma-informed care, do the security officers also receive that training?
Daniel, en el caso de organizaciones que sí han implementado atención informada de trauma, ¿reciben los oficiales de seguridad entrenamiento con respecto a ese tipo de atención?
Bueno, donde está parametrizado, donde está estandarizado como organización, se preocupan por generar este tipo de actividad de reforzamiento. Donde no, hay unos esfuerzos aislados de los proveedores de servicios de vigilancia que hacen su mejor esfuerzo tratando de acertar.
Yes, there are some organizations, particularly those with in-house security, that have implemented trauma-informed care training for their security personnel. But in many cases, what we find is isolated initiatives with good intent but poor results from private security organizations.
Very good. So just saw a question that came in about how the security as part of a response team effectively navigate trauma-informed care without getting into HIPAA issues or, personal patient information. So I think we're talking about the techniques of using the knowledge from, trauma-informed care and how to approach patients that could be suffering from trauma. And we realize that in most organizations, the security staff that responding to a patient issue probably are not shared with all the medical information, but just, say that we need to implement trauma-informed, methodologies and how we talk, how we ask questions, and showing empathy and things like that. So if that clarifies things, hopefully. So we have 5 minutes. So very quickly, I want each of you to think about it for a second. What is the biggest success that your security department, your organization has achieved? Something that you want to really brag about. First one that wants to talk, go ahead and we'll just go down the road.
I'm going to start. We have a daily management meeting for the entire organization every morning, and without fail, during our reward and recognition, our security officers are recognized. Our C-suite knows the names of our individual security officers, and I think that's an amazing achievement, that they are so recognized and embedded into our organization that they're not othered, they're not separated, they are definitely part of the team, and they're as important as the doctors and the nurses, the cleaners, everybody. And so, having our chief operating officer go and have discussions, knowing the names of our individual security officers, knowing their backgrounds and all of those sorts of things, I think really exemplifies that, involvement of our security team in our organization. And I love that.
That's fantastic. Appreciate it.
So, maybe I'm next. So I think for us, I think the fact that as an organization, as previously discussed, SingHealth has many different institutions that are within the cluster. And previously we had different sets of security uniforms, some wearing white shirts with ties, some wearing polo shirts. So there's no harmonized approach to security in terms of the image of security officers. And this gives quite a bit of an image when patient comes, even though it's under SingHealth, when patient comes to different institutions, they see different uniforms. So there's no unity or harmonized image of our security officers. And I think one of the biggest achievements that we have done is that we managed to design a security uniform that is applicable to the whole of the whole SingHealth cluster. All, I'll say, 15 institutions adopting the same security uniform, and the fact that management was very supportive of this new outlook, this new professional outlook for our security officers, and this gives an image, a more professional image to our security officers. The design of the uniform also projects a deterrent look, kind of like a military police style kind of uniform, and I think it also helps in terms of deterring unwanted behavior. And I think that's one of the achievements that, as I mentioned, it's that having that one same uniform that we have. Yep.
Thank you, Mohammed. And Daniel, what is your department's big success?
Yes, that. Ok, quizás el logro más representativo que he tenido, tanto como consultor como responsable de seguridad, ha sido, y así suene de pronto entre comillas romántico, es lograr ser visible como proceso la seguridad dentro de lo que es la instalación, la facilidad como tal, que es algo en lo que en muchas partes no es muy visible y se olvida o se deja simplemente de ser un proceso a ser solamente una función. Eso es quizás lo más representativo.
One of the successes that I've had, both as a consultant and as a healthcare security practitioner, is finding ways to make security more visible and therefore a better deterrent within different healthcare organizations, and bring security out to light so that they can be seen and be more visible.
Well done. Well, thank you so much, everyone. I appreciate all your great knowledge and expertise and everything that you shared with us. Please continue to celebrate IHSS
Security and Safety Week, and please forward all of our appreciation from IHSS staff and board of directors. Appreciate everything the officers and staff do on a daily basis. Thank you so much and have a great rest of your day or evening.
Thanks so much.
Thank you, everyone.